Today we'll cover heart failure, which is actually a symptom more than a diagnosis. Yes, it is a billable diagnosis, however, something has to cause it, therefore it is more of a symptom. Here are the learning objectives. Other recommendations include reviewing prior lectures you've already had regarding heart failure, pertinent anatomy and physiology. Also recommended reading for this lecture include Principles and Practice of Hospital Medicine, available in Access Medicine on the Ruth Lilly Library, with a chapter on heart failure. As mentioned, heart failure is more of a symptom rather than a diagnosis, and there are lots of different causes of heart failure, and this list is not all-inclusive. We'll start with coronary artery disease. This is a primary cause of reduced ejection fraction, so whenever you see that low, you should automatically want to rule out coronary artery disease. Uncontrolled hypertension causes a lot of stress on the heart, causing it to fail. Non-compliance is very important, as most of the time heart failure is a chronic diagnosis and requires a lot of attention, so patients need constant reminders to weigh themselves daily, take meds, monitor their salt and water intake, and take extra Lasix when their weight increases. Valvular disease is a common cause, usually aortic stenosis, more than aortic regurg, more than mitral regurg. Who has aortic stenosis? Usually old people or young people with a bicuspid valve. Tachyarrhythmias such as AFib with RVR or other tachycardias. Infections, either viral or bacterial, can lead to heart failure. Excessive IV fluids, and drugs or alcohol abuse, so don't forget to get a urine drug screen if necessary. CHF is no longer recognized as an appropriate diagnosis. You have to further characterize it based on the type of heart failure they actually have. You can do this by diagnosing them as HFrEF, or systolic heart failure, which is an ejection fraction less than or equal to 40%, HFpEF, or diastolic heart failure, which is an ejection fraction greater than or equal to 50%, or those in between, with an ejection fraction of 41 to 49%, which is commonly called HFpEF, or borderline heart failure. You can also diagnose it as decompensated heart failure or compensated, or acute or chronic heart failure. Why does it matter what kind it is? Honestly, it really doesn't matter much in a patient that's decompensated, as you treat them both very similarly. However, they tend to have different prognosis and treatment is slightly different. It typically defines the underlying cause, therefore helps guide the treatment. As mentioned, you should always include the New York Heart Association functional class, at least at discharge. Surprisingly, exercise intolerance doesn't correlate with LV dysfunction, so this system is used to assess the patient's exercise tolerance and should be determined when the patient is actually compensated, usually at discharge. As far as heart failure workup goes, you should always document or at least look at the I&Os and weights daily and calculate the difference so you know how effective your treatment is. As far as diet, generally you should begin a sodium and fluid restricted diet. There are no studies demonstrating what exact restrictions should be applied. However, it is generally agreed that 2 to 3 grams sodium and 1500 to 25 ml fluid restriction is appropriate. I will tell you that typically 1500 ml fluid restriction isn't tolerated very well. This equals only about 50 ounces per day, and most of the time just increasing restriction to 2000 mLs increases patients' overall satisfaction tremendously. Often I will base it off of how severe symptoms are on admission and how tolerant I think the patient will be on the fluid restriction. Next is echocardiogram. Typically, you almost always get an echo to determine the underlying physiology. You may not need it if they recently had one for similar symptoms and you already know their underlying physiology. Next is troponins. You always need to rule out acute coronary syndrome as the underlying culprit. Next is telemetry. You should always monitor the patient on telemetry for underlying arrhythmia like AFib or flutter, episodes of VT, VFib. These could always precipitate underlying heart failure. Also, while you're diuresing a patient, electrolyte abnormalities are common, which can precipitate arrhythmias. Now, when you're diuresing a patient, it is important to determine when a patient has gone from hypervolemia to euvolemia. This is done using physical exam findings including edema status, blood pressure, hypoxia levels. However, there are several labs you should review daily to determine euvolemia. These include the BUN and creatinine. When you diurese a patient, the BUN and creatinine may improve slightly if they have underlying cardiorenal syndrome or will slowly drift up. I will discuss cardiorenal syndrome in a future slide. Next is calculate the BUN to creatinine ratio. This should gradually increase, and typically a BUN to creatinine ratio of 20 to 1 or greater than 20 to 1 indicates the patient is in pre-renal azotemia and is often used to determine when a patient is getting dry. Next is bicarbonate. The bicarb will gradually increase, indicating contraction alkalosis. The exact level is not as important as the change you will see. For instance, if a bicarb changes from 30 to 31, this does not mean that the patient is contracted. However, if the bicarb changes from 30 to 39, this is pretty significant and usually indicates the patient has been diuresed quite a bit. Next is the hematocrit. Now this is less utilized but can be useful. Basically, hematocrit is dependent on volume, which is why it actually doesn't change much initially in bleeding, which is why we don't use it much in acute GI bleeds. And finally, the BNP. This is typically measured at admission, and it is important to characterize this based on the patient's prior BNPs if available, not just the current one. Sometimes you'll find that a patient's baseline BNP is 4 to 500, and you might falsely think the patient is in new heart failure exacerbation. However, if you find this to be their baseline from previous levels, then you know that heart failure may be less likely in your differential. Oftentimes you can check a BNP once the patient is dry to help determine when the patient is euvolemic. However, getting daily BNPs is not necessary. So I'll talk a little bit about drugs used in heart failure, primarily loop diuretics. So loop diuretics are key to removing excess fluid in heart failure. The number one diuretic used in inpatient medicine is Lasix. Not because it's any better, but because it has been studied the most in trials. Loops are primarily given IV in the hospital because when a patient is fluid overloaded, the intestine swells, just like everything else. Therefore, oral diuretics are usually not absorbed very well. Also, oral Lasix is only 50% bioavailable. Therefore, if a patient takes 40 milligrams of Lasix orally, this will only equal 20 milligrams IV. So you have to double the home dose to get any kind of diuretic effect in a heart failure exacerbation. The dosing of IV Lasix is 1 milligram per kilogram per day, and this is in the hospital. This is typically divided into twice or 3 times daily dose, which I will discuss a little bit more on the next slide. With Lasix, the maximum dose is 200 milligrams per day, as it causes ototoxicity. If the patient has renal dysfunction, it usually takes higher IV doses to squeeze more fluid out of the kidneys. Other diuretics used include torsemide, which is twice as potent as Lasix, bumetanide, which is 4 times as potent as Lasix, and ethacrenic acid, which is the only the loop diuretic you can use if a patient is allergic to sulfa, as this loop does not contain a sulfahydryl group. So when you're diuresing a patient, the goal urine output is 1 ml per kilogram per hour. This will make more sense in the future slides. If a patient is unresponsive or has little diuretic response to a loop diuretic, you can add a thiazide, typically metolazone, which causes complete nephron blockade to improve diuresis. Here are a few examples regarding the most appropriate diuretic use along with the therapeutic effect you'd expect. So first, let's say you have a 48-year-old white male with acute heart failure with reduced ejection fraction weighing 80 kilograms. Remember, with reduced ejection fraction, you always worry about coronary artery disease. Therefore, you would get serial troponins and EKGs. I'd also be more inclined to get a cardiology consult on this patient. So the most appropriate treatment would be Lasix 80 milligrams, 1 milligram per kilogram, and then you would divide this into BID dosing. So the patient would get 40 milligrams BID IV. Usually Lasix comes as 20, 40, or 60 milligrams IV. The therapeutic objective for this patient would be around 80 mLs per hour of urine, which would be around 1900 mLs per day. You might want to reassess the patient around 4 hours after the initial IV Lasix to determine if we need to go up or down on the dose. Now let's say you have a 78-year-old African American female with heart failure with preserved ejection fraction weighing 120 kilograms. First, what would be the cause? Well, in this age group in African American females, I would worry that either blood pressure was related, perhaps non-compliance with diet, meds, or fluid intake was the cause. The treatment for this patient would ideally be Lasix IV 40 milligrams TID. The therapeutic objective would be a goal urine output of 120 mLs per hour, or around 2,900 mLs per day. Now, I just wanted to review a little bit more on the treatment guidelines for acute versus chronic heart failure. Obviously, you've probably had this in prior lectures, so you may want to go back to that to review in more detail if you're unsure. We'll first start with chronic heart failure. First is diuretics. We've already discussed loops, however, other diuretics are commonly used in heart failure. These include aldosterone receptor antagonists, and they work on collecting ducts and can decrease morbidity in New York Heart Association 2 through 4 classes with heart failure with reduced ejection fraction. Spironolactone, remember, can cause gynecomastia, whereas eplerenone is the other the other potassium-sparing diuretic that does not cause gynecomastia. Next is ACE inhibitors and ARBs. These should be used in everyone. Even if the patient is hypotensive, you should still use a low-dose ACE or ARB. You typically use ARBs if the patient's intolerant to ACE inhibitors, such as having a cough. The nice thing is you can increase these daily to control their blood pressure. Next is hydralazine plus nitrate, which is commonly called Bidil. It's BIDIL. And this is used as an alternative if the patient can't tolerate an ACE inhibitor or an ARB. Bidil has been shown to decrease morbidity and mortality in African Americans with New York Heart Association class 3 to 4 and used as adjuncts with ACE inhibitors and ARBs, or when those are contraindicated. Also remember, hydralazine decreases blood pressure but increases heart rate, so avoid this if the patient has tachyarrhythmias such as AFib, sinus tach, or SVT. Isosorbide dinitrate, or Isordil, is typically used for heart failure, and this is dosed at TID dosing, whereas isosorbide mononitrate, or Imdur, is used typically for angina, which is once daily dosing. Next is beta blockers. These should be used in everyone, just like ACE inhibitors and ARBs, especially in heart failure with reduced ejection fraction. Increased sympathetic tone in heart failure equals increased norepinephrine levels, which equals increased cardiac remodeling, which equals leading to arrhythmias and increased mortality. So basically, ACE inhibitors and beta blockers both prevent remodeling. They should be increased slowly. Beta blockers should be increased slowly, though, over 1 to 2 weeks, whereas ACE inhibitors can be increased quickly, usually daily. The 3 approved beta blockers for heart failure are carvedilol, metoprolol, and bisoprolol. Metoprolol succinate is typically used more for heart failure, whereas metoprolol tartrate is typically used more for hypertension and coronary artery disease. The problem is that beta blockers are also negative inotropes, so you should abstain from starting them if the patient is acutely decompensated. If patient has been on a beta blocker for greater than 90 days and they've been compliant with it, it's usually okay to continue this on admission, even if the patient is decompensated. Next is cardiac glycosides. These include digoxin, which decreases hospitalizations and morbidity. However, it really doesn't improve overall mortality. Obviously, you can't use digoxin if the patient has underlying chronic kidney disease. You also will find that digoxin is primarily used in patients with heart failure and AFib. Next is vasodilators. As mentioned, these include hydralazine, nitro, and minoxidil. Remember, vasodilators should be avoided or used with caution if a patient has aortic stenosis, as they decrease preload, which aortic stenosis patients are dependent on. Next, we'll talk about acute heart failure management more in detail. First, diuretics. These are used all the time just to treat the overall volume overload. Beta blockers. You've probably been taught to hold beta blockers as mentioned earlier. However, remember that they do have negative inotropic effects, but if the patient has been stable on it for greater than 90 days, it's usually okay to continue these. For patients with severe decompensation, you should usually hold them no matter what, but for moderate to severe decompensation or hypotension, the dose should be either decreased or held. For mild decompensation, as mentioned, I would probably continue this, and you'll find the same instructions on UpToDate. Vasodilators, remember these reduce preload and strain on the heart and to decrease blood pressure. Oxygen, only use if the patient's hypoxic, which most of them are. Morphine will decrease anxiety and sympathetic tone you get when you have decompensated heart failure. And last but not least, dobutamine. This is the primary inotropic drug used in cardiogenic shock. So I know that I've thrown a lot of information at you at once. However, let's break it down into a sample case so that you would know how to diurese a patient while they're in the hospital. So I'll give you an example here and we'll take it day by day. So let's say you have a 60-year-old female with a history of diastolic heart failure who presents with dyspnea on exertion, increased JVD, 3+ lower extremity edema, pulmonary edema on chest x-ray, and a BNP of 700. She admits to increased salt intake for the past few weeks and increased lower extremity edema. Her weight is 80 kilograms currently. Her baseline oxygen is on room air. However, in the emergency department, she's requiring 4 liters nasal cannula. Patient takes Lasix 40 milligrams orally daily at home. So her inpatient, or let's say her ED labs for the first day, you can see her hematocrit's 40%, creatinine 0.80, BUN 15, bicarb 24, and sodium of 134. So what diuretic dose would you give? I'll give you a second to think about this. So the patient weighs 80 kilograms, so you would want 1 milligram per kilogram per day divided BID or TID. So let's say you give the patient Lasix IV 40 milligrams BID. So the next day, approximately 24 hours later, the patient still feels short of breath at rest, but is better than admission. The patient is down 1,100 mLs and weight is decreased 1.5 kilograms. She still has 3+ lower extremity edema. So you can see her day 2 labs. So on average, if you calculate for 1 ml per kilogram per day, she should have lost around 1,900 mLs per day. However, she's only lost 1,100. Her BUN to creatinine ratio is around 18, which is similar to what it was the previous day. Her renal function and bicarb really haven't changed all that much. And although you see a little bit of clinical improvement, the patient hasn't overall changed that much. So what should you do with her diuretic dose? So let's say you decide to give the patient a little bit more Lasix. You increase it to Lasix 60 milligrams IV BID. You could also add metolazone at this point for complete nephron blockade to increase her diuresis. So the next day, patient's shortness of breath has resolved and she is now requiring only 2 liters of nasal cannula. Remember, her baseline is room air. She is down another 1,500 mLs and weight is down another 2 kilograms, which is 3.5 kilograms total. Her lower extremity edema is improving. So you can see from her labs on day 3 that they still have changed. Her BU into creatinine ratio is still, though, around 18, and her bicarb is slowly trending up, but not anything significant. What should you do? So, after review of everything, you decide to keep her Lasix the same and keep going with her diuresis. So the next day, patient feels well and is able to walk around her room on 1 liter nasal cannula. She is down another 300 mLs and weight is down another 0.8 kilograms, which is 4.3 kilograms total. She has 2+ lower extremity edema. After review of her labs, you can see that her BU into creatinine ratio has significantly worsened. She's now 27, which is considered pre-renal. Her blood is definitely more concentrated. As you can see, her hematocrit has increased dramatically, or well, a little bit. So you decide the patient is pretty close to euvolemia. So what should you do? At this point, I would probably stop all of her diuretics. Now, the next day, patient feels well and is requiring 1 liter of nasal cannula. She is positive 150 mLs and weight is up 0.1 kilogram. She still has 2+ lower extremity edema. Now, review her labs on day 5. You'll see that her creatinine has gotten a little bit better. Her BU into creatinine ratio has also improved slightly. Her hematocrit stabilized. Her bicarb has stabilized and gone down some. So at this point, you start the patient back on Lasix 40 milligrams orally daily to maintain that euvolemia. Upon discharge, you schedule her for outpatient BMP in 1 week and for PCP follow-up very closely. During the hospital stay, she should get multiple people coming in her room, including you, for heart failure exacerbation to prevent her from coming back to the hospital with this. Also, it would be advised for her to follow up in a heart failure clinic in 1 week if this is possible. So now that we've reviewed a case on how to diurese a patient, typically this takes around 4 to 5 days to diurese a patient, so it ends up being anywhere from a 3 to 6 day hospital stay. It's important to understand that the heart and kidneys always work together. In fact, 64% of patients with heart failure also have chronic kidney disease. Heart failure is the most common cause of death in chronic kidney disease stage 5, so end-stage renal disease patients usually pass from heart failure exacerbation. It is important to understand that when one organ fails, it typically causes the failure of another, and that's usually the kidneys. This is what we refer to as cardiorenal syndrome. There are 5 types of cardiorenal syndrome, which I don't expect you to memorize, but have a rough understanding of. Type 1 cardiorenal syndrome is when acute heart failure causes acute renal failure. Type 2 is when chronic heart failure causes acute renal failure. Type 3 is when acute kidney injury leads to heart failure. Type 4 is when chronic kidney disease causes heart failure. And type 5 cardiorenal syndrome is when systemic conditions leads to heart failure and renal failure. This could include conditions such as diabetes, amyloidosis, vasculitis, or sepsis. Prior to a patient being discharged for heart failure, it is important to provide patient education throughout the hospital stay so the patient understands why they have the heart failure in the first place. Assess their physical activity by means of determining their New York Heart Association class. Stress how important medication compliance is. Most of the time, we will instruct the patient to take an extra dose of Lasix if their weight increases greater than 2 pounds in 24 hours. There are other instructions that are commonly given to patients also. These patients also need close follow-up with cardiology or cardiac rehab. A lot of hospitals have incorporated heart failure clinics, which are typically run by an APP, to closely monitor patients to keep them out of the hospital. Sudden death assessment is important if the patient's ejection fraction is less than 35%, and the cardiologist will help determine if a life vest is warranted. Dietary counseling, including salt and fluid restriction, along with monitoring edema status, is also very important. And as mentioned, BNP measurement to determine what their dry BNP is at discharge, so when the patient returns in the future, you can tell how much they are exacerbated. And here are the sources I used to complete this lecture.